Hello, everyone. Thank you for joining us today. My name is Olatoyosi Odenike, and I am a professor of medicine at the University of Chicago and director of the leukemia program here. And today it's my pleasure to be able to address this question regarding what are the management considerations for accelerated and blast phase MPNs or myeloproliferative neoplasms. So just to put this in context, we are addressing the Philadelphia chromosome negative myeloproliferative neoplasms, which are a group of hematopoietic stem cell diseases that when they are in the chronic phase, survival is generally measured in decades. So these diseases include polycythemia vera, essential thrombocythemia, and primary myelofibrosis. In the chronic phase, patients do survive many years. Patients with the lowest survival tend to be those who have primary myelofibrosis, but even those early on, again, can survive for many years. When the disease progresses to the accelerated phase, which by definition includes patients who have 10% blasts circulating in the peripheral blood or in the bone marrow. So 10% are all up to 19%. Those classified as accelerated phase, whereas those who are in the blast phase are patients who have blasts, peripheral blasts that are in the 20% or more, or bone marrow blasts in that range. Patients in the accelerated phase have a median overall survival in the 12 to 18-month range, while those in the blast phase have a very short survival in general in the 3 to 6-month range, often less than 6 months. So, what are the management considerations in this regard? So I, in general, when I meet a patient with accelerated or blast phase disease, I try to think about what do I know about their disease, and specifically, what is the molecular and or cytogenetic profile of their disease. We advocate at the outset comprehensive profiling of patients' peripheral blood or bone marrow samples to try to identify what mutations these patients harbor. And the significance of that is that some mutations may be potentially targetable, and some may allow us to choose one approach to therapy versus the other. In general, I strongly advocate enrollment on a clinical trial wherever possible, since we know even in today's day and age with contemporary therapies, survival is still very limited and there's a lot to try to learn. I evaluate fitness for therapy. So who are the individuals who would be more fit for an intensive approach versus those who are unlikely to benefit from an intensive approach, and where we would be more likely to advocate less intensive approaches. And as I said before, I factor in the molecular profile of the disease. So for patients who have TP53 mutations, for example, which is highly enriched in accelerated and blast phase disease, where up to 20% or more of patients may harbor a TP53 mutation. I generally favor a less intensive approach. That is, I tend not to pursue AML type chemotherapy in those patients because of the poor outcome. So even if patients are fit to tolerate it, they are unlikely to benefit. Such patients, I would advocate clinical trial enrollment very strongly. If there isn't a clinical trial that is appropriate or applicable, I would recommend hypomethylating agent-based approaches. So drugs like azacitidine or decitabine, either as single agents or in combination with other agents such as, venetoclax, for example. The goal in patients, particularly those who are fit for therapy, is to move them as quickly to a transplant as possible. And I often will prospectively evaluate for a donor as well as refer patients early for transplant consideration. For patients who have an IDH1 or IDH2 mutation, those patients are potential candidates for a targeted approach, incorporating either the IDH1 inhibitor, ivosidenib, or the IDH2 inhibitor, enasidenib. And there are retrospective data that support, that kind of approach. And this is now being investigated in prospective clinical trials. So I very strongly favor a targeted approach using one of those agents, depending on the mutation, either as a sole agent or in combination with others, but preferably on a clinical trial whenever possible. And for patients who have other mutations that do not fall into the aforementioned categories, I have relative equipoise between choosing an intensive versus a less intensive approach, but I do generally favor any approach that will, if the patient is fit, result in them being able to get a transplant as quickly as possible. So I will not pursue an intensive approach, even in a fit individual, unless I am sure they can then be moved to an allogeneic stem cell transplant, because the bulk of the evidence suggests that patients only benefit from intensive chemotherapy approaches if they can then be quickly moved to a transplant. Otherwise, for the majority of these patients, the less intensive hypomethylating agent-based approach is what I would favor. And to summarize, I would say, clinical trials are very strongly encouraged and favored in this patient population. They still they still represent a population that represents a huge unmet need in terms of effective treatment approaches. We also need significant improvement in our knowledge and understanding of the biology of these diseases, of the processes, not just genetic mutations, but epigenetic and other mechanisms that propel these diseases from the chronic, more indolent phase to this sort of accelerated blast phase, which is a lot more aggressive. And finally, I think when we are treating patients in the chronic phase, we need to do everything we can to identify those patients early who have a high risk of progression to accelerated or blast phase disease and intervene in those patients early in an effort to prevent this from happening and to refer patients for transplant evaluation early on for those who are potentially transplant eligible. Thank you very much for your attention.